We are the USMLE channel on YouTube.
Your very own free USMLE channel for your USMLE prep.
Forget about paying for tutoring and courses. Now we are here to help you, and our videos will always remain free.
Subscribe and hit the bell button now to receive notifications for 3 new high-yield and highly engaging videos per week.
Check out some of our sample videos right here.
Welcome to valves and valvular heart diseases along with maneuvers. As you guys already probably realized during your study of step 1, step 2, you're thinking, okay, they're asking me a lot of questions on these valves and maneuvers, right? It's actually very easy, especially after you're done watching this. So check this out. So now think about your mitral valve. Your mitral valve is normally supposed to close during what time? During your systole, right? During your systole, your mitral valve closes and your ventricle starts to contract. Once the pressure opens up the aortic valve, the blood is pushed out. Now if your mitral valve is so floppy, right, if this is your chamber and your mitral valve your ventricle starts to contract, you have your isovolumetric contraction, your aortic valve is supposed to open, but if your mitral valve is all floppy, you're gonna get gush of blood back into your left atrium throughout the entire systole. So you will get a pansystolic murmur, guys. Beautiful. S1, S2, a pansystolic murmur. And there you go, you will get a pansystolic murmur. It's that simple. Understand the murmur, never ever memorize it. Mitral valve prolapse is more like a milder or earlier version of mitral regurgitation. What happens is your mitral valve's here, right? So your cusps are still kind of holding on. Your ring might be stable. What happens is so early part of mitral valve is still floppy but not completely flapping out. So again, your left ventricle is starting to contract. Your left ventricle contract. Mitral valve ring is pretty strong. So what happens? The cusp kind of go up. Cusp goes up during mid of systole, makes a click noise, right? So if I put it like this, and if your mitral valve ventricle starts to contract, your mitral valve starts to flop up, click. Ventricle contracts during systole, mid systole, mitral valve goes up, click. So mid-systolic click followed by a late systolic murmur. That's what you're gonna hear. A mid-systolic click. So S1, S2, a mid-systolic click followed by a late systolic murmur is the murmur you're going to hear with the patient with mitral valve prolapse. Rule number 3 is to do with afterload. Now what is afterload? Afterload is basically the pressure that your left ventricle is working against. That's it. That's what afterload is. Now the basic rule of thumb with regards to afterload is all forward flow murmurs, right, are affected by afterload. Same goes for backward flow murmurs. But the way you're going to understand this is this. There is a driving force, guys. Now when you think of a forward flow murmur, I want you to think of the heart as the driving force. All right. For instance, forward flow murmurs are mitral stenosis, aortic stenosis, HOCM. These are forward flow murmurs because the murmur occurs when the blood goes from up to down, right? It goes from your atrium to ventricle. So forward flow murmur. Mitral stenosis, aortic stenosis, same thing. It's a forward flow murmur. What about mitral regurgitation? It's a backward flow murmur, whereas aortic regurgitation is also a backward flow murmur. You get the point, right? So my point is, if you have a backward flow murmur, if you increase your afterload, you will increase the intensity of the murmur. Very good. There you go. So now let's think of how I can increase my afterload. The number one thing you could do is hand grip, guys. So by doing a hand grip, how do I raise the total peripheral resistance and as a result pressure? Because I want to raise the pressure here, right? It's a bunch of equations, guys. If you guys remember your Ohm's law, right? Flow is equal to pressure divided by total peripheral resistance. Right, total peripheral resistance, which also means if I change the equation, I can say that total peripheral resistance is equal to pressure, right? It is equal to pressure. So what I'm saying is when I do a hand grip, I am increasing total peripheral resistance, and as a result, I'm increasing pressure. So again, if you guys recall, total peripheral resistance is equal to viscosity times length. divided by radius to the power of 4. So if I'm constricting my arterioles, I will decrease my radius, right? If I decrease my radius, what happens to my total peripheral resistance, guys? It goes up. And if my total peripheral resistance goes up, my pressure goes up. So you get the point. If you do a hand grip, you are going to raise the pressure of your backward flow murmur, right? So your arm is the pump. So what's going to happen is, if I increase my afterload by doing a hand grip maneuver, I am going to increase the intensity of which murmurs, guys? Backward flow murmurs. Increase pressure, goes up, right? So aortic regurgitation, right? And mitral regurgitation. There you go. So mitral regurgitation and aortic regurgitation, if you increase the afterload, you will have increased intensity of murmur. That's it. It's so simple.
Now in the PCI unit, after they catheterize the patient, depending on the degree of occlusion they find in the coronary vessel, they have two choices. Either to perform balloon angioplasty if the occlusion is less than 70%, or to put a stent there if the occlusion is more than 70%. Now both these procedures aim to widen the blood vessel, the lumen of the blood vessel, and thus to restore the coronary blood flow through it. Now if you need to put a stent, if you have two choices, either to put a bare metal stent, and here you have to keep the patient on the same dual antiplatelet therapy that we just discussed for a minimum of 1 month, or you can put a drug-eluting stent, which we normally do and prefer because of less rates of restenosis. Now here you have to keep the patient on the same dual antiplatelet therapy for a minimum of 1 year. Now why is that? It doesn't make much sense, right? It should be the other way around. The question you should be asking yourself just about now is, what exactly is the drug these drug-eluting stents are releasing? And the answer is, they release chemotherapeutic agents. So now these immunosuppressants will inhibit the vascular smooth muscle cell proliferation. Thus it will take longer for them to get covered by endothelial cells. And just to complete the topic, we have two generations of drug-eluting stents. The first one use sirolimus and paclitaxel, and the second one use everolimus and ozotaurolimous. Now we tend to use the second generation drug-eluting stents because they cause less inflammation, less restenosis, and more rapid endothelialization. Let's manage our patient with non-STEMI or unstable angina now. Luckily, we treat both of them in the same way. And by the way, at the end of this video, I will be showing you tables with the whole algorithms of managing the acute coronary syndromes. Now, the initial drug treatment here for both of them is the same one we used in STEMI. The same box mnemonic drugs, along with the ACE inhibitors and the statins, with the only difference here is that the most beneficial P2Y12 inhibitors are the prasugrel and the ticagrelol here, and you want to stop them 5 to 7 days before the patient undergoes CABG procedure, of course if he needs one. After that, we need to evaluate the patient's mortality risk using the TIMI score. Now TIMI stands for thrombolysis in myocardial infarction. And based on the number of points the patient receives, we will manage him further differently, as you see in a bit. Now let's see what the TIMI characteristics are. We have 7 of them, and each one gets 1 point for a maximum of 7 points. Now the first one is 65 years or more, 3 or more risk factors for coronary artery disease, which by the way the risk factors we'll be discussing in the next video, in the stable angina video. The third one is use of aspirin within the last 7 days. The fourth one is known coronary artery stenosis of more than 50%. Fifth one is ST changes on EKG. The sixth one is positive cardiac enzymes, and the seventh one is 2 anginal episodes within the last 24 hours. So you want to memorize this because they will come in handy. Patient with a TIMI score of 0 to 2 points has low mortality risk, so he doesn't need any invasive procedure just now. What you need to do is send him to do an exercise stress test to check if we can induce ischemic changes in his heart. More details about the different stress tests in the stable angina video that follows. Now, on the other hand, if the patient collects 3 to 7 points, he is at high mortality risk. So we need to send him to the PCI unit. Now there, after he gets catheterized, depending on the degree of occlusion they find, they have several options. If the occlusion is less than 70%, they can perform balloon angioplasty. Or if the occlusion is more than 70%, they can either put a stent there or schedule the patient for CABG procedure. Now the stents we have already discussed. Let's see the CABG indications. CABG, by the way, stands for coronary artery bypass grafting. So here are the indications that we need to remember. If the occlusion of more than 70% is in the left main coronary artery or right after its bifurcation. So imagine this is the left main coronary artery and branches out to the LAD and the left circumflex. If the 70% occlusions are right here in the most proximal parts of LAD and left circumflex, it's basically the left main coronary artery is occluded, right? So here you perform also CABG procedure. Or if you have 3 vessel disease, one of them being LAD, or 2 vessel disease and the patient is diabetic, or you have failed stent, low ejection fraction, or the patient is symptomatic on maximum therapy. Alright, so this concludes our video about acute coronary syndromes, and I know that there is a lot of information out there, but once you start doing question, you will see that you're gonna get tested on the same information that we just discussed, but in different types of questions. Here I would like to remind you of the famous saying of Mahatma Gandhi: live like you're gonna die tomorrow and learn like you're gonna live forever. So keep having fun, keep learning, never settle for less than perfect understanding, and enjoy your studies. See you in the next video.